Hey, how are y'all?
Doing fine.
Good. We're still battling snow and ice up here.
Rick, is that you with the snow and ice up there?
Oh yeah.
Yeah.
Yeah, I just today was the first I got to Corinth on Sunday about 2 o'clock, and Oxford's still a little bit of a mess, but first day I've been able to get down here back to Oxford.
I've been up here all week and it is a mess.
I'd like to report that the Hattiesburg American had the picture of Dan Edney on its front page today.
I bet they had to do a second printing.
No doubt. You know how many people have been waiting all these years for that to finally happen, and now it has. Yeah, those papers flew off the shelves.
His family bought all the copies, probably.
Exactly right. That's exactly right.
And you did a good job on the air.
Thank you, ma'am.
Two, four, six, seven. We have a few people missing. We'll give them another minute. Is Jim Perry one of the telephone numbers? Is that the 956 or is that? Jim's not on yet.
My calendar had the wrong link. I had to go back to the email to find it again. So Jim may be having that problem.
Leanne, it's good to see you. We missed you at the strategic event, but
I missed y'all.
we're glad you're here today.
I was in La Jolla, which is beautiful, right? But we were in a meeting room all day long. We could have been at the Atlanta Airport Hotel instead of La Jolla for as much as outside as I saw. But I did miss being with y'all. I hope it was a productive meeting and more productive than mine was, for sure.
It was a good day. We're gonna do it next January, so you'll get to experience that.
Perfect. Thank you.
Well, 203. Let me see.
I'll send a text to Jim.
Is 899?
Well, you send a text to Jim and just be sure he's close. That's 7. There's Jim. Jim landed. Very good.
We're good with 8, right, Chris?
We've got a quorum. So why don't we go ahead and get started? Hello, Jim. Glad you made it. Hello, everyone. I'm going to stray on the agenda slightly because I heard so many good things about the public health report card that was presented yesterday. And I thought Dr. Edney could give us just a 2 to 5 minute update on the report card, what he said in the presentation, but also the event. Can I turn it over to you to do that?
Yes, sir, Mr. Chairman. Thank you. Just for the board members, this is the official report card that you'll get in an email version of it. And it basically takes our findings from the annual report that I presented to you at the last board meeting and just consolidates it down into this format that we traditionally have done with state medical every year for quite some time. The press conference was very well attended and a lot of interest. and basically just went through our numbers again, but just being able to show some encouragement that we do see some positive movement in some key areas. And I can't emphasize enough the importance of the movement with obesity, and that it has trended down, and us moving from 50th to 45th is a very impactful improvement. And then when you combine that with diabetes improvement, moving from 50th to 48th, I know it still sounds bad and it's not where we need to be, but it's significant improvement at a population level. And those two work synergistically to improve cardiovascular outcomes. And cardiovascular, with stroke and heart attacks, kill more Mississippians than anything. And having obesity and diabetes showing improvement, and that's going to be a population improvement down the road. And as we keep working with hypertension, that hopefully that likewise will help. But just sharing with the legislature and the public, obesity rates are down, HIV rates are down, tuberculosis continues to do well. And this is all despite the pandemic years where there was a lot of service disruption. And so having those trends continue through the pandemic are extremely important. As I shared with you before, opioid deaths being down significantly. Our overall report card from Commonwealth is the same, but we're able to see some changes that they have not had reported yet. So I'm optimistic that we keep pushing like we are and continue to have partnerships with state government at large and our community partners, that we will see our rankings improve. And that's determined that happens. And I don't want to blow this trumpet too hard. And all I'm going to say is that our maternal infant numbers look promising for 2023. It's raw numbers. Certainly can't release those, but it's the first bright spot that I've seen in maternal infant death for several years. So I'm just encouraged. We still have the same usual suspects killing Mississippians, and that's cardiovascular number one, malignancies number two. Both of those largely preventable with proper primary care intervention early in the disease and proper screening and prevention techniques. And then accidental deaths remain number three, which hits our children pretty hard. And when I presented to the Senate Committee on Public Health last week, they were very interested in this information, asked great questions, and their focus was on these outcomes. So it was quite a good hearing, I thought. And we'll be presenting to House Public Health next Tuesday at 1 o'clock. And our new chairman, Creekmore, asked for me just to do the same thing, present to his committee what we did in the Senate. So just happy to have some bright spots to report out, Mr. Chairman. And as I said, y'all will be getting copies in your email.
Very good. So be looking for that. Now to get back to the main agenda item that we were going to, the board had hoped to have a robust discussion about what our response should be to the state health plan report that we received and were presented at our last meeting, specifically on the needs of CON reform in the state. The CON committee met to sort of do a deep dive on this and to bring back some ideas to the board for discussion. The HMA report, I think all of us feel, is comprehensive and exceptional. It's certainly a good starting point, if not a final word, but it's certainly a good place for us to start and an extensive discussion about the needs of the state at a macro level. Our role as a board should be at a macro level. We should be advising our state health officer about what sort of direction we want him to take with CON, especially in his discussions as an expert with the legislature, and they will be talking with him extensively. And he needs to be able to report what the board feels is the appropriate direction with this. And that's okay if we have various views. We can have different views about this, and I think we should express different views. And I think the truth about CON is that it may seem easy at times, but it's extraordinarily complicated, and the ramifications and the ripples about changes could have negative outcome on some of our essential providers as well as positive outcome. And what we're hoping for is specifically to focus on, try to come up with how can CON be reformed in a positive manner that helps access to care. And that was a point that came up at our meeting, that the term we should really be talking about is not really about institutions in rural areas, but the ability of citizens in our rural areas to access the care they need. And so I want us thinking about access to care when we're discussing this. Beside giving our state health officer some direction about, there may be some statutory changes that need to be made, and we need to let the state health officer know some areas he needs to do some research. We probably need to do a lot more research in most of the areas that we're looking at and have an interest in. We have experts we can consult with. The CON committee can meet again and go into further detail with experts. And also the legislative committee can meet to consider things as well about the legislative aspect of this. As well, there probably, and Dan told the committee, there are probably a lot of things that can be addressed at the department level with CON to reduce the administrative burden, to reduce the cost, and really streamline a process that we haven't streamlined in a while. So there are some things that really aren't legislative that can be done. There are things that we as a board can ask our state health officer to do a deep dive and look and see how we can improve CON, the process, and how the department itself and its regs impact CON and complicate it, and how we can make it easier for people to access care throughout the state. With that, I've probably said enough. I wanted Jim Perry, who had encapsulated sort of the thinking or most of the concepts on the board, and we have sent out, if you have your computer close by, if you have not gotten the document from January 10th, 2024 that was sent out about 30 minutes ago, which is Jim's assessment of what we discussed at the CON that he's going to be talking about now. So, Jim, is it okay if I turn it over to you?
Sure. Thanks, Luke. We started this process a couple of years ago, but it really kicked it off more last April when the board adopted our vision statement for modernizing the state health plan. And not to rehash that, but we've talked about it a significant amount, but I do think it's important to just remind all of us that our conversations about and our effort to modernize the state health plan is not just about CON. And that's really the main, I think a principal problem that a lot of the board had under the department staff had was that the state health plan had turned into a CON regulatory manual as opposed to what the statutory definition of the state health plan is. And I think that the HMA report and other discussions will help us move in that direction. I think that when we asked the legislature for additional funding to facilitate this analysis, and we engaged HMA as a consultant to help us work through it. As we described in our vision statement, it was contemplated this was a long process, and we wanted to have we set out a timeline, and I referenced it in the discussion that was circulated to y'all from our conversation at the CON committee meeting on Wednesday, that we wanted to, by the end of calendar year 2023, to have the goal of being able to be in a position to revise at least some aspects of the state health plan and having an initial review so we could give some feedback to the legislature, effectively show a little bit of return on the investment, if you will. I would assess that we're in the third inning of a 9-inning baseball game. There's a lot more work to do. I think that was always intended when we hired HMA. And there's a lot more conversations that need to be had with stakeholders, which is, providers, of course, but, others throughout the state. And there's more research to do, like Luke said. So what we were thinking that we would do, we can walk through each of these. This is sort of a continuation of what we discussed at our board meeting last week, is 3 buckets of action items. And ultimately my motion, if that's what's appropriate, Luke, is that we would like to be able to get to the point of saying that this approach that the CON committee outlined on Wednesday would be the policy of the board, to provide guidance to Dan as he's engaged with policymakers, legislature, governor, on issues that may come up on CON in this legislative session, but then also to give, in category 2, direction to the staff and team to action items that we want them to come back with, for actions that the board can take on their own. And then third is to try to take the information that HMA and other outside interests have produced of areas that we want to learn more about. So maybe there's more action in the future that I would hope that there's more action the board could take, along the lines Luke said, to make this whole process work better. And then maybe there's future recommendations we want to have in terms of our legislative agenda for state policymakers. And when I say legislative agenda, we have a legislative agenda that we approve every year. In my 5 years of the board, I don't know that we've ever actually looked at statutory language that we're proposing. And that's not, I don't want us to go down that road. I mean, there's people who've run for office and they have that lane, but I think we should talk about what our principles are and where we think we ought to go. And certainly as the legislature may consider statutory changes, I would hope that they would, consult with, our staff to make sure that it really works and kind of fits within our principles to the extent that the legislature agrees with us. On those 3 buckets, and it's in your email, on that first one, statutory considerations, there's 4 areas that I think we all have agreed with. There's urgent statewide needs to address, mental health issues. And I know that Dan, he can talk about this. He's been talking to Wendy Bailey at Department of Mental Health to get her views on this, because we work so much with them on these issues: mental health issues, substance abuse issues, maternal and infant health care issues, and rural medically underserved areas. The CON committee's discussion was to have it as our opinion that we ought to statutorily exempt psychiatric residential treatment facilities. And I say we ought to exempt, we don't have that power, only the legislature and the governor can do that. But we would, if we were engaged in the legislative discussions, that our position would be that we would exempt psychiatric residential treatment facilities, substance use disorder services, and perinatal services, maternal and infant care. The fact is that I think in general, if any of those came up and there was an application made to get approved, I mean, there's a demonstrated need. Also, the fact is that if all those CON requirements were eliminated today, I don't think that all of a sudden we would have spouting out of thin air new psychiatric residential treatment beds, or new OB units in medically underserved areas. I mean, there's much broader issues at play, commercial reimbursement rates, Medicaid coverage, workforce concerns. I mean, there's a broad range of issues that really we don't have the power to fix, but we need to be a part of the solution. And removing this last barrier, to Dan's point of, there was a couple of rural hospitals that have wanted to expand services in their footprint, but the concern about the year-long CON process was creating a chilling effect. So let's get out of the way of making that, so it makes it easier for those things to happen. Since our conversation, Luke and some others, we've talked about the spirit of the conversation we had on Wednesday, and which was, what if you had also 24/7 acute care service, existing service providers in rural, medically underserved areas, if they want to add services within their geographic footprint, good. But we would like that to be exempt. But at the same time, however this ultimately got structured, we really want to be cognizant of that balance of protecting the economic viability of providers that are already in a tough situation in terms of operating margin with the types of services they're providing, the populations they're serving, with also getting out of the way so that they can better pursue the operating models that they want to, in their view, provide better and more services to that population. And then lastly, on the statutory changes, there are some inflation adjustments that are in state law for certain things. It's a little vague and it's not consistent. We would suggest that the capital investment limits should be increased to some amount, recognizing that inflation has had a real impact over the last couple of years. That's bucket one. Bucket two, in terms of direction of the staff, first and foremost, and these, I should note that all the things what I just talked about were referenced in the HMA report. I thought the HMA report was helpful. I don't agree with every single thing in it. Don't disagree with every single thing in it. It's a useful tool, but I thought it was helpful on all those points. Similarly, on the actions for the board and the department staff, restructuring the health plan so it's in two parts. The first that's more focused on broad priorities, metrics, trends, recognition of best practices. So that's something we could update annually, and it effectively gives guidance to the state health officer. This is what we need to be working on. And it hopefully, with better data, and that'll go to a later point, it can also be a guide for not just the department, but other state policymakers to better inform collaborative policymaking and planning. And then the second part of the state health plan is all the CON stuff, which probably is not going to be able to get updated as quickly. Second, really kickstart the process for a comprehensive review of the need criteria and formulas that are required by the current CON process. That's going to be a time-consuming effort. It's going to need to require an awful lot of input from people around the state, consultants, statisticians, providers, other stakeholders, et cetera. Third, and as longtime members of this board know, this is my one of my biggest pet peeves is we got to improve the integration and alignment with other state agencies and licensure, so we can improve our data collection and accuracy so that it's consistent, and we can get a better picture of what our situation is and what it isn't. And so that would help not just the department and CON applicants, but also just policymakers for other action items. And lastly, look at ways to streamline the application process, make it easier, especially for those smaller providers that may lack the resources to submit or defend an application. Just try to make this easier on all parties, including our staff. And then lastly, the areas that the CON committee were particularly interested in just more work, and I think this goes back to conversations over the last year. Our vision statement is, are there other statutory exemptions we ought to be looking at? What's the impact of that? I mean, is that good, bad, especially the rural versus urban differential? Looking at areas where we have a high rate of approved applications, like end-stage renal disease, the addition of service lines, beds, and equipment for existing hospitals. We're looking at consistently 90+% approval rate on applications. Is that because people are not applying, or is that because it's just a process and is it going to get approved? So can we make this a little bit better? That may or may not be the case. And then lastly, there was a lot of discussion about abeyance regulations. Some thinking that, yes, we absolutely ought to do something, and some people thinking, no, we shouldn't. So let's have more conversations about that. Luke, I'll stop there, open it up for discussion, but that's ultimately, I'd like to get to the point where we could effectively, to the extent we don't change this, or if we do change it, then we would have a motion so we can give guidance to Dan on these three buckets.
Yeah, thank you. I think this was an excellent job of preparing the three buckets and what we discussed. I do want to hear from everyone here, and I know I want to encourage discussion on this. Who has any opinion about what you just heard? Or about the HMA report?
One question that I have, how many people in the department are required or work in anything to do with the CON process? Just roughly.
About 4. We have,
Plus our legal team.
plus the legal team is invested.
So you're only getting about.
It is interconnected with licensure as well, which it includes a lot more folks.
You're only getting about 18, averaging 18 applications a year. Is that correct? Is that what the report said?
Benny, say what you said one more time.
Aren't we getting about 18 applications per year? Is that what the report said? Do I remember that correctly?
CON applications total.
Yeah.
Jim is nodding. I do not know.
Okay.
Well, I think the answer, that's what the report said, Benny. I mean, I have not.
Well, that's where I thought
Yeah.
I was picked up on that. Thank you.
Yeah, I applaud the work of the CON committee, and I really I think that the recommendations that have been made are very thoughtful and have been very carefully thought out. I think that you know, every act has an effect. Most changes or actions that you take have the potential for unintended effects as well. And I think that moving forward very prudently to address something that has been a part of our healthcare system for so long with CON is wise. And I like the way that carving out specific services that for which there is universal agreement, really, that we have a need across the state for, and then continuing to study others is a very reasonable and prudent thing to do. I also think that allowing facilities that are currently open 24/7 to provide healthcare the opportunity to expand their services, because obviously, especially in more rural areas, more underserved areas, there are hospitals that are open 24/7, but they don't, but there are services that people in the community could use that they don't have access to now, and it becomes somewhat onerous for some people and inconvenient and the travel of a significant distance to receive those services. Allowing those, making it easier for those hospitals to add services just makes common sense. And I really like Jim and CON committee members, the idea of our state health plan not being centered around CON, but really splitting it up into two parts. I think that's something that that has lacked, and that it falls squarely on the shoulders of the Board of Health to provide guidance to the health department and to Dr. Edney with a component of the state health plan centering around measuring outcomes from previous interventions and making plans, providing a roadmap for Dr. Edney and his team on an annual basis going forward. I think it will help us be more proactive instead of reactive regarding a lot of problems that are plaguing Mississippians from a health perspective. So I really applaud that that recommendation. that we sort of divide up the state health plan accordingly.
Yeah, Dr. Davis, I completely agree. That is my favorite bullet point on that entire document is the splitting up of the health plan because I appreciate all of the work that y'all do and the discussion around CON. But when I first joined the board, I'm like, oh, let me look at the health plans. I was surprised that it was all full of CON stuff. I'm like, where's the stuff? Like, what are we supposed to do? So I really appreciate the idea of splitting it up so that we can have one part that is truly focused on the health of Mississippians and then the second part on CON. So thank y'all for that recommendation. I fully support that.
So what other comments do we have?
You know, I think the CON process is extremely complex, and I'm not sure that any of us I'll speak for myself, have a working knowledge of it, of the process and the history of the process. So I think we have to be very diligent as we move forward. And I think Jim mentioned including some stakeholders, having some communications with them. I think we have experts in the state that are very knowledgeable of the CON laws that we could utilize to help educate us and to get their thoughts on different aspects of the CON policies and procedures, and if there are opportunities for us to make changes. Now, I agree with all the issues related to the access of care in the underserved areas, and y'all have heard me say this multiple times. I don't know that we can do anything with the CON laws that's going to improve the access of care in those areas significantly until we get providers and healthcare workers to go to those areas to provide those services. The workforce challenges, and Jim, I think you mentioned that in your comments, the workforce challenges are significant. And those of us that operate in the rural areas have a very clear understanding of that. Even in the metropolitan areas, Luke, I think I talked to you one time when you couldn't get a patient admitted somewhere because there wasn't a bed. There was a bed, they just didn't have staff to staff that bed.
Mm-hmm.
So that's a major area that we have to think about when we talk about access of care, because the actions we take are not necessarily going to provide access to care. And then on these rural hospitals, letting them expand, I like that idea. The fact is the affordability of these rural hospitals, because I'm telling you, they're struggling every day to make payroll. And it's a major challenge in these, and Dan Edney, you can tell, you can attest to that fact. You've talked to the people, you know how it is out there. So the affordability to expand services, everybody would like to expand services, but the affordability to do that and get paid for it is a major issue. So I think we need to pause, have some of these people that we've talked about come in and talk to the CON committee and get some additional information, additional education, or even the whole board. It doesn't matter to me, but I just think that's something we strongly should consider.
Benny, I think that, sorry to jump in, Luke.
No, please.
I think especially on the needs criteria and all these other issues we're talking about, I mean, we absolutely need to get a whole lot more input, and I hope the legislature gets their input as well. I mean, you know, there's very few things that the board truly can do on its own as it relates to CON stuff. I think that the needs criteria and better data are probably the 1 and 2 action item. The one item that you didn't mention in your list of challenges for improved access to care, and whether it's rural or elsewhere, that again we don't have anything to do with, but I just feel like we should acknowledge is commercial reimbursement rates. I mean, it's a I just didn't want that to go unsaid.
Yeah, I think you're right, Jim, and I apologize. I said this to the committee, free market and thinking about competition and the cost of healthcare becoming more affordable. I disagree with that. In Mississippi, about a third of our residents are on Medicaid. Then we have a high Medicare population. We have some commercial insurance that's out there that pays us about 25% less than they pay the neighboring states. And then you've got folks that are uncovered. So they're probably the majority of those are going to be indigent care. So thinking that there might be some opportunity on your co-insurance where you might can negotiate some of that down if allowed. But the idea of having more providers of the same services and you getting a more competitive pricing for that, I just don't buy that.
I do think that despite all those challenges, there are certain circumstances, like Dan referenced our CON meeting on Wednesday. I think one or two examples of some rural providers that wanted to do something where CON was in the way. And I think that while it's not going to be a panacea at all for these particularly high, we all know statewide need issues, moving forward on that can maybe make it just a little bit easier for somebody who is looking about doing something. And I said this to the CON committee on Wednesdays, but so forgive me for those people repeating myself, but my bias is the Adam Smith world of you don't improve quality and lower price by limiting supply. And that's the way it works in a free market, but we don't have a free market in healthcare. And, between federal regulations and a well over majority of people in Mississippi being paid for by the government, whether it's Medicaid, Medicare, VA, or state employee health insurance, we just have to acknowledge that. And I think sometimes that gets lost in the discussion and debate. But I think that for these borderline crisis type areas, if we can make it a little bit easier, where I think there is a much more broad consensus, so we can then focus on some of these other issues to the extent that the department and board has anything to touch on them, I think would be a good thing. And again, we don't have the ability to do any of it. It's just more of if Dan is in conversations with policymakers, it's makes it so he has guidance from us, and they can have informed conversations. Like I said, this is third inning of 9. But sorry, Benny, I think I just cut you off.
Well said.
No.
Benny, what were you saying?
I'm just going to make a comment to what Jim was talking about in the rural area where the CON got in the way, And I think, Luke, you made a very good comment in our committee meeting where you have to look at the other side of that coin too, of how it might hurt another provider there. For example, if it's an ASC and that ASC is competing against a rural hospital and pulls all the outpatient surgeries out to the ASC, what's going to happen to that hospital? So all of that has to be considered, I think, when you're thinking through this process.
Right, and that's why for what we had talked about here, that we were suggesting the guidance Dan be focused on making it easier for those who are in fact doing that 24/7 acute care services. Frankly, those who are embracing the loss leader.
I think kind of looking at these buckets, if everybody's kind of commented on it, what I was thinking is we should look at each bucket. And if we look at the first one, and as Jim has said, one of the things we want to do is give our state health officer some guidance about what we'd like him to do more study on to look at. And I think that we also, as a board, as Benny was saying, is it would be good maybe to even speak with some stakeholders, and there are CON experts that we could find beside HMA that probably could give us some advice about they could look at these specific low-hanging fruits and some other things and give us an idea as a CON. I would recommend the CON committee in the next 2 to 4 weeks, gather them together and some rural hospital administrators and discuss possibly some ways. Are these low-hanging fruit as we perceive them? What negatives do they see with these? And do they see anything else that's a low-hanging item that we haven't seen? And I think we've got the time as the legislature is evolving from my legislative contacts. I mean, I think things are evolving slowly, and And as the discussion on CON, if we could have another meeting and look at this, I think we can provide our macro role of giving Dan and our staff more resources and more thought on this process. What do you think, Dan?
Yes, sir. And we do have some time with the legislative process. And I'm listening to your really good discussions and soaking it in. So, I'm not waiting to, if I get calls on Monday, then I can still share what, I can't say what a board position is, but here's what the Board of Health is looking at. I have had conversations with leadership of the Hospital Coalition, Healthcare Coalition, and the Hospital Association, so that they understood the work that you were doing and made sure they had copies of the report. And they were comfortable with the process, where you're going. They shared with me some of their agenda, which is taking on some of the things that you're already bringing up. And I'm being told there's consensus between the two hospital groups of where to go with, from their standpoint, with CON this year. And I've also had a good conversation this morning, as Ms. Perry said, with the Director Bailey at Department of Health, who was fully supportive of the areas you're looking at. She did bring up a caveat of, we have to remember one role that CON plays. By statute, it requires a reasonable amount of quote unquote charity care. And that's part of the CON process. And if we have areas that we remove CON, there still is going to be a need for there to be a certain level of community support. We would have to look at that issue. Right now, it all comes through CON.
And Dan, you and I talked about that. I mean, it sure seems like that's something that's much more appropriate for licensure. The CON, it shouldn't be about governing patient safety and quality type stuff. I mean, then I recognize that Wendy was talking about indigent care on psych beds, but the licensure can address some of those matters, I would think.
Yeah, I think so. Right now it's a statutory requirement in CON, but I do think there are alternatives if the legislature is changing.
Oh, and there's no way with CON to really assess the amount of charity care that people are performing what they're doing.
They had to make a commitment to it, but the CON itself has no authority to enforce.
I mean, licensure is not checking to see if they're following.
Well, they going forward, they'll have to, because we have CON for labor and delivery and hospitals, and that requires a certain number of deliveries per year. And we need to make sure our CON holders are serving the community as they have committed to, and that's another big issue in that respect is diversion. And we have, historically diversion has been for a number of hours, and now it's becoming for numbers of days, and that's putting our smaller hospitals in a crunch, trying to transfer to higher levels of care during the surge at wintertime. And so there's so many issues to look at. We have plenty to do moving forward. I do think that there are stakeholders that are going to be introducing legislation very soon that's going to address some of the low-hanging fruit that's been a common conversation.
But I do think if we could get together a group of experts and maybe some stakeholders and sort of discuss with the CON committee who those people are, and try to get a group that we can listen to and ask questions and address these principles that have been brought up that we think are low-hanging fruit.
And then Mr. Perry.
But look, are you, I mean, I think that the two things are not mutually exclusive. I think that providing guidance now to Dan, because if the bills are being drafted, people are deciding whether or not to introduce whatever, move forward. I mean, I think we're going to be studying this, and the legislature's going to be studying this and having broad conversations. We should keep on doing those things, but I think providing guidance as to this is in principle, the direction we think we ought to be going. I think that we can do both.
Well, I think that's what we're telling him, basically, he's hearing, but if you would like to, we could make a motion to do that. From a macro level, that these are our principles that we'd like to do further research and study them more, but we think these seem to be our principles for now, and they can change as the process evolves. But I think our attempt to provide meaningful reform is something that these principles would continue to endorse and allow to go forward.
Well, like I said at the beginning, I think we're in the third inning of a 9-inning game.
Okay. So we can take these one at yes.
Luke, I got a question. You mentioned, I think I heard in your comments that Dan had a list of items that he thinks that might could streamline the process within the CON department. Did I understand that?
Yeah, that was the
correctly?
next item. And why don't we, before we vote on, do any kind of vote, why don't we go there? Because I think that one's easy. I do think the actions for the department, I think we could say we'd like the department to go forward with these, right? And this department can go forward researching, and they're gonna, staff is gonna have to do what they need to do. But as far as restructuring the state health plan into 2 parts, I mean, I sense consensus with that, and we can vote on that and everything, but I think all of these items, we had wanted the department to do what it could do to streamline and improve CON processes. Now, that's gonna take them doing it there's a process to that, and you have an expert that will help us look at that.
Mr. Hubbard, what we're actively doing, just having listened to y'all's conversation already and being in full agreement, is Chris is going to be ordering a performance improvement project out of our PI department, looking specifically at how CON process goes now within the agency. And then also ask Wayne Jameson, our internal auditor, to do kind of an audit of the system for us. So we're getting that independent view and look for some improvement points. And y'all know, I've only been in state government 17 months, and I'm hanging on the best I can, because everywhere I turn is inefficiency, much of which is imposed upon us. But I have no doubt that we have room for improvement in terms of process improvement in that area. And we do need to make sure you do have awareness that even with the limited staff and having reduced overhead significantly recently, we're still, and y'all having increased the fees for CON, we're still underwater. We get no legislative support for that. So we basically make up the difference with agency funds for CON. And so we have to stay lean and mean in that area, but I do think that we'll find areas of improvement. So we'll be moving through that. And I've told Chris that this is on editing time, not health department time.
But as far as the actions for the department can go forward with all of those.
Yes, sir. And we're taking directive from you, and we will work those bullet points as far as we can. And there may be areas where we have to have more data from the Sullivan study, and we will let you know when we're hitting areas where we need more information and what we're doing. Some of the things that I think we can proceed forward on our own.
And when could you give that back to us? Do you think that as action progresses, you will let us know?
Yes, sir. Well, I will tell you, that'll be a report out to you every week.
Okay. All right.
So Dr. Lampton, I mean, I think, are we not in a position to, if there's no other discussion, to vote on the recommendations of the CON committee?
I think we
sounds
could.
like
It
sounds like there was broad agreement. I didn't hear anybody, obviously, there are concerns about how we move forward in the ways that we might or might not tweak the CON process in Mississippi. But I think that balance was struck very nicely by the CON and the recommendations that they brought to us. So if discussions are complete in that regard, then I would be comfortable to make a motion that the board as a whole accept the recommendations of the CON committee.
I think that would be appropriate. Rick, are you making motions or?
Yeah, I'm sorry. Yeah, seconding the motion.
Yes, seconding the motion. All right. Well, I want to get through by 2, so we're approaching that time. The motion would include all 3 buckets, okay? Now, we also realize we're gonna ask at the CON committee to get together a group and study these in more detail and ask staff to study these in more detail. So this is an evolving process, but that from a basic standpoint, this is one of our principles of CON reform, that we think these are things that need a deep dive and should be considered. And also the bucket 2 about the actions for the department, we want that to begin and immediately, and see how we can make progress, realizing that each one of those numbers is going to take a little bit more time, and we want it done in the most professional way possible. What other comments? If that said, there's been a motion, there was a second. All in favor, say aye.
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 Any opposed? All right. I think we've done all we can do on a Friday afternoon. All right. Is there any old business or any business that the board would like to bring up before we adjourn? I do want to thank Jim Perry for his hard work in getting together this document in such a fine manner. I think I want him to write everything that the board ever does. He's in charge of, he's our historian and our stenographer and writer.
He's a great
All right.
typist too. That should be noted. Great typist.
And Mr. Perry, I'll be generous and I'll double your pay, sir.
So does that mean that you'll stop losing money on the stamp that you put on my check to send for mileage
Hey,
reimbursement?
you know what I found out today? That can be direct deposited. So if you would like your mileage direct deposited.
My 3/4 of a mile reimbursement for
Yes.
37 cents that I
You'll
get.
get 37 cents in your bank account every meeting. With that said, I appreciate all of y'all. The deed is done. See y'all soon, okay?
Thank you.
Thanks.
All right.
Thanks,
Bye.
y'all.
Bye, everybody.
Have a good weekend.